Hi all, my name is Abdullah Ahmed and I'm a first-year medical student at Brown University. The title of my paper is Benchmarking Modern Named Entity Recognition Techniques for Free Text Health Record De-Identification. I have no relevant disclosures. Here are the learning objectives for reference. And here's an outline of my presentation. There's been a massive increase in the use of electronic health records by hospitals and physicians all around the US. This can largely be attributed to the HITECH Act of 2009, which provided financial incentives to hospitals to adopt EHRs in their practice. One of HITECH's goals was to promote the use of EHRs in scientific research, including in NLP and medical information extraction. However, there is a problem: HIPAA. HIPAA's privacy rule protects most individually identifiable health information held or transmitted by a covered entity or its business associate in any form. I will refer to the underlined bit here as patient health information, or PHI. HIPAA's privacy rule safeguards patients' identities by restricting the distribution of EHRs that contain PHI. HIPAA defines 18 categories of PHI listed here. HIPAA necessitates that all 18 of these categories be completely removed from an EHR for it to be used in any downstream application. Just to give you an idea of what this looks like, here's an example of a synthetic EHR with the PHI bolded. To comply with HIPAA's privacy rule, all the bolded entities must be identified and removed. There are 3 steps that must be taken to allow for the downstream use of EHRs. First, identify all the PHI within the text. Second, classify the category of each PHI from the 18 categories specified earlier. And third, replace the original PHI with synthetic PHI. We focused on the first 2 steps of this process. Other research, including one of the talks in this session, is focused on the third step of developing algorithms for realistic replacements of PHI. For simplicity, I will refer to the first 2 steps as the de-identification task. We can frame this task as a named entity recognition problem. The input of an NER system is a sentence S that is a list of tokens, or words. The output is a list of tuples, where each tuple corresponds to a PHI entity. IS here is the start token, IE is the end token, and T is the PHI category. Just as an example, here's an input sentence: Mr. Sam Lee is a 70-year-old man. The system should output 2 PHI tuples. First, the name of the patient, Sam Lee, and second, their age, 70. It is essential to have the spanning token IS and IE because entities are often not just one token, as is the case with Sam Lee. De-identification systems fall into 4 general categories. First are rule-based systems, which use regular expressions to match medical text with predefined structures of PHI. Then there's machine learning, where the idea is to use statistical methods to predict PHI entities. Hybrid methods combine rule-based and machine learning methods into a single system. All 3 of these methods suffer from generalizability issues and require extensive feature engineering on the developer's end. The most recent and successful approach is deep learning-based NER. Deep learning methods learn complex patterns between the input and output space, making them more generalizable. In addition, they do not require any feature engineering on the developer's end. The model itself is able to learn a latent representation of the data that is useful for the task at hand. The major downsides of deep learning models is that they are not interpretable and require lots of data. Nonetheless, due to their current success, we decided to focus our research on deep learning methods for de-identification. In particular, we aim to determine which modern NER design combinations perform better when tackling the de-identification task, as well as to test how well these methods generalize. Let's move on to methodology. Before we get into the specifics, here's a high-level overview of how our NER systems operate. First, we take free text EHRs and tokenize them so that the sentences are separated into sequences of words, or tokens. Second, we convert these tokens into numerical vectors, or embeddings, thereby forming a distributed representation. Third, we feed these embeddings into some context encoder to output a new set of vectors. And finally, we feed the context encoded vectors into a tag decoder to output a final set of PHI. The first step of our methodology was to collect the EHR data. We collected data from 2 different sources. First was from the Center of Biomedical Informatics at Harvard Medical School. They provided us with a data set that contains about 1,300 synthetic EHRs that have been manually annotated with PHI. These serve as the data we use to train our models and quantitatively evaluate their performance. However, we were also interested in qualitatively testing our model's generalizability, so we collected real EHR data from Rhode Island Hospital. Our second step was pre-processing. The goal of this step was to take raw EHR data and convert it to a form that our NER systems could consume. Ultimately, what we wanted is an input and output that looks something like this, where you have an input sequence of tokens and an output sequence that assigns a tag to each input token. To construct the input sequences, we built an advanced tokenization module adapted specifically to medical language. To construct the output sequences, we utilized the beginning inside-outside, or BIO method, to encode the labels. This method accounts for the fact that PHI entities can span multiple tokens, as you can see with the name entity here. Our third step was building the deep learning-based NER models. This figure is an alternative illustration of the first slide of our methodology section. Each NER model can be completely characterized by the design combinations or choices made for the middle three steps: distributed representation, context encoder, and tag decoder. The way we built our systems and ran our experiments was by swapping out different methods for each middle step and empirically testing how it affected the quantitative performance. Here's another illustration of our system: tokens to embeddings to context encoded vectors to tags. The first middle step is the distributed representation. We tested two methods for forming distributed representations: word level and character level embeddings. Character level embeddings are especially useful for processing tokens that were never encountered in the training set and thus do not have learned word level embeddings. We call these UNC tokens. The second middle step is context encoding. The context encoder is responsible for capturing and synthesizing the contextual and semantic information contained in the input sequence. Without a context encoder, input tokens would be processed independently of each other. Therefore, context encoding allows tokens to influence how other tokens are processed. We tested two context encoders, BiLSTM and transformers. LSTM, or long short-term memory network, is a form of recurrent neural networks that sequentially process an input sequence. Compared to standard recurrent networks, LSTMs are better suited to capture long-term dependencies in the sequence. A BiLSTM is simply two LSTMs that process the input sequence in two directions, from left to right and from right to left. Transformers are a little bit different in that they do not process the tokens sequentially, but rather in a parallelized fashion. The model learns how much attention, so to speak, a token should pay to every other token in the sentence. Transformers have yielded state-of-the-art results in many NLP tasks, but are yet to really be tested as context encoders in the de-identification setting. The final middle step is tag decoding. We tested two tag decoders, Softmax and Conditional random fields. Softmax predicts each token's label independently. It creates a probability distribution over the 18 PHI categories, and the category with the highest probability is selected as the output tag. Conditional random fields, rather, maximize the probability of an entire sequence of PHI tags altogether, thereby capturing inter-tag dependencies. If you have ever encountered Markov chains, CRFs operate quite similarly. This slide summarizes the models we built. Each row corresponds to a different combination of distributed representation, context encoder, and tag decoder. Moving on to training. All our models were trained using Cross-Entropy Loss, the standard for multi-class classification tasks. The probability of a sequence is given by the outputs of Softmax or CRF. Results. This slide lists the metrics we used to quantitatively evaluate our systems: precision, recall, and F1. These metrics are the most commonly used in NER tasks. The overall performance of each system was evaluated using micro and macro versions of the previously mentioned statistics. Micro average calculates metrics at the corpus level, whereas macro average calculates them at the document level and averages the results over all documents. Here are the global results of our system, calculated at the macro average level. BiLSTM-CRF was the best performing system according to all three metrics, followed closely by BiLSTM. Furthermore, Transformer CRF had higher precision but lower recall than just Transformer. We also wanted to test how our models performed across specific PHI categories. This slide shows these results calculated at the micro average level. BiLSTM-CRF was still performed the best according to F1, but there were some other interesting results. The addition of a transformer to the context encoder in Transformer BiLSTM improved precision in both age and contact categories. Character embeddings significantly improved the precision of location and slightly improved the precision of date, yet suffered tremendously in recall as a consequence. BiLSTM had a higher recall than BiLSTM-CRF in three categories. Let's dig deeper into some of these results. Although transformers improved precision in two categories, they were overall less effective than BiLSTMs at encoding context. This may be accounted for by the uncontrolled sentence lengths in EHRs. Due to the lack of structure in medical text, There are sentences that contain over 1,000 tokens. As a result, our transformer model may have tried to capture long-term dependencies via self-attention in the absence of any meaningful relationships. Moreover, other research has shown that semantic extraction is correlated with the number of attention layers used. The transformer we used only had 2 layers of attention, so it may have only partially captured the semantic information. Performance did improve when a BiLSTM was stacked on top, which may have compensated for the limited semantic extraction. Character embeddings improved precision in several categories, yet significantly decreased recall. The increase in precision is likely due to the model's ability to classify tokens never seen in the training set, as evidenced in this table. The decline in recall is likely because the character embeddings were not fine-tuned during the training process. While CRF's tag decoders generally improved the F1 score, our results show that they decrease recall for both BiLSTM and transformer context encoders. We hypothesized that certain sequences of tags in the training set became favored by the model, leading to unseen sequences receiving low likelihoods in the testing set. In practice, a hybrid method that leverages the strength of each model based on its performance in individual categories may function best. For instance, BiLSTM-CRF could be used to output an initial set of candidate PHIs, and then that could be filtered by other models that have higher scores in certain PHI categories. Now let's move on to our qualitative results. We evaluated BiLSTM-CRF, our best model, on a sample of EHRs collected from Rhode Island Hospital. Here are a few examples of our model's output. We noticed that it somewhat generalizes beyond the training dataset. It was still able to categorize crucial PHI, like medical record numbers. However, it failed with sentences and phrases whose format significantly differs from the training set, as well as with tokens it never encountered, such as COVID-19. One particularly revealing example is the classification of Rhode Island Hospital versus RIHER, its abbreviated form. Our model could correctly classify the former because it extrapolated from similar hospital names encountered during training. On the other hand, it was not able to correctly classify the abbreviated form and thus misclassified it. Other research has shown that fine-tuning models on labeled data from local hospital EHRs may improve model portability. In conclusion, BiLSTM-CRF is the best performing encoder-decoder combination for the de-identification task. Character embeddings and CRFs improved precision at the cost of recall. Transformers alone underperformed as context encoders, and qualitative assessment of BiLSTM-CRF on local EHR data showed some success, yet the issue of model portability remains. And future work may explore pre-processing steps that are specific for medical text, such as dedicated medical tokenizers and enforcing structure upon nodes such that semantic and syntactic information can more easily be extracted. Thanks for listening. I'd like to thank my advisor, Dr. Eickhoff, our lifespan collaborator, Dr. Abbasi, and AMIA for inviting me to speak at this event.